Welcome to Neurology News Network. I'm Jenna Pasco.
And I'm Matt Hoffman. Let's get into the news from this week. The FDA granted approval to fremanezumab, the second preventive therapy for migraine, joining ipilimumab in the CGRP inhibitor class. The approval for the Teva product was based on supporting data from 2 studies in the Phase 3 HALO clinical trial program. In the trials, the fully humanized anti-CGRP monoclonal antibody reduced monthly migraine days by more than 50% in roughly 45% of patients with episodic migraine and about 40% of patients with chronic migraine. The wholesale cost for the antibody will be $575 for the monthly dose and $1,725 for the quarterly dose, which is the same price that was announced for ipilimumab in May. Teva noted that out-of-pocket costs would vary based on the insurance provider, but could be as low as $0 per month for some patients.
When it comes to mild cognitive impairment, new study findings have suggested that behavioral activation is more beneficial for Black individuals with mild cognitive impairment. Led by Barry Rodner, MD, from Sidney Kimmel Medical College of Thomas Jefferson University, the study included 221 patients with aesthetic MCI. They were randomized to receive either behavioral activation, which included goal setting and action plans to reinforce the practice of healthy activities, or supportive therapy. The incidence of 2-year memory decline was 1.2% for those receiving behavioral activation compared to 9.3% for those receiving supportive therapy, for a relative risk of 0.12.
That's good news, considering there aren't any pharmacologic interventions available to patients with MCI, unlike in multiple sclerosis, where the count on disease-modifying therapies numbers more than 15.
You know the saying, sometimes you can have too much of a good thing. The number of choices for physicians has led to a lot of trouble in deciding which DMT will be the most beneficial for patients with MS.
Exactly. Although, according to the director of the Comprehensive Multiple Sclerosis Center at Stony Brook University, Dr. Patricia Coyle, it's probably okay to emphasize the more efficacious therapies as good options.
Coyle said that while she doesn't necessarily think one agent is head and shoulders above the others, there are several factors that go into the decision-making process, including administration, efficacy, and adverse effects.
And those adverse effects have been the biggest obstacle for some therapies, according to Coyle. Although, when Neurology Live sat down with her, she noted that there is an anti-CD20 antibody in development that could change that. Let's take a look.
So I don't think there's one major disease-modifying therapy. I really don't. Among the needle injectables, glatiramer acetate is one of the more popular because it doesn't require any blood monitoring whatsoever, and because it has absolutely the highest pregnancy exposure and seems to be completely safe. I think people feel comfortable using the orals. They've been used in a lot of individuals. There are refinements in some of the orals that are coming. These are currently in testing, so-called second-generation drugs. With regard to the monoclonals, I think the biggest stumbling block, they're high efficacy, very convenient, you have guaranteed adherence. The stumbling block has been the adverse effects. The newest monoclonal, the anti-CD20, is the only one that doesn't have a REMS program in place. So I think that that's an agent that is going to become more and more popular.
For more direct access to expert insight, head to neurologylive.com. This has been Neurology News Network. Thanks for watching.